and welcome to the BS+Beer Show. Of course, BS stands for Building Science. Tonight's topic is indoor air quality and health. I'm Travis Brungart, and I am actually in the car, so I'm not drinking beer, but I do have a coffee, which won't surprise anyone. So, as you know, BS+Beer is an independent grassroots movement to share building science knowledge through our local meetup groups, and of course, this, our Zoom show. The brew crew and our guests volunteer our time each month to bring you what we hope is a fun and informative discussion. Now, this evening is special. As you might have already seen, it's our 5th anniversary show, and we're happy to share it with all of you because 5 years ago, we didn't have a plan. We just kind of got online to see how others were doing at the start of the pandemic. And since that time, it's grown into something that we care deeply about, and that's sharing BS far and wide and having fun doing so. We now have over 160 hours of free content available on YouTube, and we're particularly proud to have encouraged over 40 local groups across the US and Canada, and one in Australia. Shout out to Greg O'Byrne. We're grateful to you, our audience, and to all of the industry experts who have generously shared their time and expertise with us over the years, and really to everyone who's contributed along the way in any facet. We, of course, want to just take a second to remind you that we couldn't have done it without you. So if you have your beverage, raise a glass. Cheers to all of you, and cheers to BS+Beer. And with that, I defer to my good friend, Mike Maines.
Thank you, Travis. To continue the opening announcements, we do encourage you to find a local BS+Beer discussion group or to start your own. Visit the BS+BeerShow.com for more information on how to do that, or just get in touch with one of us. Tonight, please post your questions and comments in the chat box. Be sure to click all panelists and attendees, or everyone, depending on your device. Otherwise, Zoom reverts to panelists only, and I will post occasional reminders in the chat. We want everybody to be able to see your questions. You can find the video recording of tonight's show and audio-only versions of the show on our website. Again, that's the BS+BeerShow.com. We would like to thank our behind-the-scenes people helping us bring you new and improved content and messaging, including these sweet shirts. Charlotte Mustard, Mackenzie Kruger, and the rest of the team at IMW, and Doug Duval, along with Peter Boring at Motif. A couple of announcements. The Building Science Symposium, Travis's project, will be in Seattle next week, April 8th and 9th. Amazingly, there are still a few seats available, so grab one now. Speakers include Steve Bazek, Sean St. Amour, Jake Bruton, Tim Euler, Brian Euler, Bailey Brown, and our own Ben Bogey. I don't think I've ever seen both Eulers together at once. Is that like a magnetic thing or attraction or repulsion? I don't know.
It's a twofer. You know, you get a discount.
The next symposium will be in Sacramento, May 6th and 7th, and includes some of the folks I just mentioned, plus Ross Trethui and Dr. Building Science himself, Joe Stiebrick. And I will put a link, or somebody will put a link in the chat to the symposium website. You don't have to mention that Emily is in the car and may not make it. And if anyone else has announcements, please post them in the chat. And and I forget to say, last weekend, I was at JLC and got a good head cold thanks to the airborne infectious diseases there. And so I am drinking a kombucha and ginger ale tonight. And with that, I will turn it over to Ben Bogey.
Oh my goodness, this is historic. I am the first person and only person, I believe, to currently be drinking a beer on the BS+Beer Show. And this evening, I went deep into the archives and I pulled out a Three Fontainen, which is a 5-year-old Belgian lambic that I'm going to enjoy in honor of being with all of you here for 5 years. But this evening, I have the distinct pleasure of introducing Dr. Stephanie Taylor. Dr. Taylor received her MD from Harvard Medical School in Boston, Mass. in 1984. For the next several decades, she practiced clinical medicine and did academic research in cellular growth mechanisms. She is now the medical advisor for Think Light Air, her partner in IAQ management, to decrease diseases and promote occupant health. We'll drop a link to that in the chat box. To communicate the fascinating convergence of human health, microbiology, and architecture, Dr. Taylor writes monthly columns and biannual feature articles for Engineered Systems magazine and publishes in other healthcare journals. She is an ASHRAE Distinguished Lecturer and is on the Epidemic Task Force and Environmental Health Committee. The three of us here at the BS and Beer Show have been fortunate enough to have seen Dr. Taylor at the Building Science Summer Camp a couple of years ago, where she shared an intriguing presentation on her unique perspectives on buildings, indoor air quality, and how they affect our health. Dr. Taylor, did we miss anything there? I'm sorry, Stephanie, did we miss anything there?
No, I'm so glad you didn't say go on any longer. I forgot to ask you not to do a long introduction. But I don't have a beer, but I do have a Vermont. This is my contribution since I don't have a beer. Come here, come on. Come
Who's
on.
this?
I do have a
Special guest.
very beautiful yellow lab. And so those of you who saw me at summer camp, I had a different dog with me who passed away, sadly.
Oh, sorry.
Yeah, it was. But we won't talk about that. So let me get my share going. As I said, I'm really pleased to be speaking with you tonight. And my title, Unlocking the Power of Indoor Air to Support Our Health, is really pretty understated. What I'd like to say is that managing the indoor environment is really the key to the survival of human beings, in my opinion. I think it's that powerful and that important. And I hope you'll at least understand my perspective in a few minutes. So I'd just like to show slides for maybe 15, 18 minutes, and then hopefully we can have a discussion. So to get going, hopefully, clicker will work. So I do a lot of things. I still work at Harvard Medical School. I'm involved with ASHRAE, and I'm really honored to now be the medical advisor for Think Light, which is just an amazing company and group of people to work with. And I work with the USGBC. And there you see Luigi. So in the next 15 minutes, I just wanted to really cover three areas. One, and those of you who saw me at the Building Summer Camp have seen these slides, but how did I, as a physician, decide to go back to architecture school and really focus on building management? It's not that I don't like medicine. I love medicine, but I'll tell you what really was the early trigger of my transition. And then secondly, we talk about indoor air quality, but how do we define quality? Is it comfort? Is it energy? Is it what we can smell? So I think it's really important that we are clear about what we're managing to. And thirdly, once we've decided what we're going to manage our indoor environment to, what is the guiding principle? How do we do that? And what is going to motivate people to manage indoor air quality for things other than, for example, energy? Things that are things that have an easily quantifiable cost benefit. Health is not as easy as energy. So I'd really love to talk about that at the end and get your input. So to get going, so this is the beginning of my journey. This is actually me when I was in my 20s. I've been in medical school and college forever. So I decided to have a break, and I went to Papua New Guinea for 4 months, and I had just an amazing time. And when I was in PNG, I was stationed at the Wewak General Hospital, which you can see here. This was in the 1980s, so things have changed, but even in the 1980s, the conditions were more primitive than you see in US hospitals. On the left, you see the men's tuberculosis ward. Beds were close together. Thankfully, there was outdoor air ventilation, but the conditions didn't exactly look ideal, to me anyway. Patients would have their families help take care of them. On the right, that's me in the operating room with flip-flops on my feet. Sometimes we didn't even have gloves during surgical procedures. So I was really concerned about patients getting new infections. But in fact, when I look back over my records, which I kept carefully, patients did pretty well. They went home when we thought they'd go home. They didn't get new infections. So at the end of this, I went back to Boston to the Harvard teaching hospitals that look great, very pristine, single rooms, private bathrooms. And I became increasingly aware of this epidemic of healthcare associated infections. So infections that people got from the hospital environment. It's a huge problem. And these aren't just numbers. These are real people. The gentleman in the middle had a ski injury. He tore his meniscus. He was supposed to go in for a one-day procedure, and he came out 4 months later after having almost died from a MRSA infection. The little girl on the right was one of my oncology patients who survived leukemia and almost died from an infection. So I looked at these conditions and I thought, wow, there's something going on here besides surface hygiene, besides antibiotic prescription, besides hand hygiene. And so I talked to my mentor, and this is a plug to be a mentor or get a mentor. But again, that's me in my 20s. And I talked to my mentor, Dr. Folkman, and he said, never underestimate the role of the environment in patient healing. So what I'm going to talk to you about from here on is not specifically about patients and hospitals, but it's about how our environment, specifically our indoor environment, affects the health of all of us. So how do we know what our goals are when we're talking about indoor air quality for health? First, I think it's a good idea to define who's indoors with us. What are we actually measuring to? Oops, here. So as I'm talking, everyone is breathing, I hope. They're drinking beer. Little aerosols are coming out of our airways, about 100 microns in diameter, and they carry the particles and the organisms that are in our mouth, nose, sinuses. That's normal. You can see this engineer leaving skin particles on her desk. You can see particles floating off of her body. There's resuspension from surfaces, because we do live in a three-dimensional world, so surfaces communicate with air and vice versa. You can see particles coming out of her nose. That's normal. Doesn't mean she's dripping on her paper. Her GI tract is illuminated because we have a lot of particles and organisms in our digestive system that communicate with the room. You can figure that out yourselves. And again, you can see interactions between surfaces in the air. And furthermore, depending on how tightly sealed your building is, you'll have particles and microbes going from the outdoor environment indoors, depending on the degree of infiltration. So I really like that video, not to freak people out. So if anyone's germophobic and is sort of cringing right now, I don't want you to, because even though as human beings, we are all shedding lots and lots of particles and microbes into our environment at the rate of about 37 million per hour per person. So if you go into a hospital or into any building, it takes about 5 to 10 minutes before your microbial signature is in that space. And then this is really fascinating. Depending on the building materials indoors, depending on the ventilation types, patterns, humidity, temperature, and the uses of spaces, certain of those microbes will be selected to survive. So if you think about how powerful that is, it means the indoor environment is really the force for natural selection for microbes. So what we've learned, and our learning is really from new tools. Well, they're not that new anymore. We now can use metagenomic analysis tools such as PCR. We all know those initials. I don't know how many of you know that PCR stands for polymerase chain reaction, but it's a way of identifying the DNA and RNA of all of the microbes and cells that are in a building, that are on us and in us. And so by using these tools, we've learned a lot. So what have we learned? We've learned that our old way of thinking about microbes is really very wrong. And this might be a hard thing to get your minds around if we've come out of a pandemic not that long ago. We've got avian organisms to worry about now. You know, ASHRAE focuses a lot on 241, but we need to understand that only a small percentage of microbes are actually germs or bad for us. 95% of them are good for us. And so when we think about building management, and when I say building management, I'm not really talking about an operating room or a bone marrow transplant unit where you have almost no immune protection, but in our average building, in our homes, offices, schools, and even in most of the hospital, you have to be careful with your hygiene because you don't want to eradicate the good organisms and only leave the bad or pathogenic ones around. And if you really want to create a healthy and diverse microbiome indoors, there's a great way to do it. Get a dog. So unless you're allergic to dogs, this is kind of a good, healthy scene right here. If this is what your bed looks like, that's okay. Cats are slightly different, but we won't talk about cats right this second. My microbiome diversifiers look like this. The only issue I have is my husband doesn't like dogs, but so that creates another problem. But clearly he loses here. But so seriously, dogs have a very diverse and robust microbiome. And that might be a little bit different from what you're used to thinking about. So I just wanted to highlight the knowledge about a diverse microbiome indoors as we think about managing our buildings. So let's go back to indoor air quality and not just focusing on microbes. Is indoor air quality for health really such a big deal, or is it just something that we're talking about right now? Well, the fact of the matter is it's a huge deal. So think about our airborne exposure. Air is like our most powerful social media. You know, we are exchanging particles and gases and microbes with everyone, whether we want to or not. Poor air quality causes about 1 in 6 deaths worldwide. It's the largest risk factor for premature death, second leading cause of non-communicable diseases. And beyond smoking and beyond infectious disease, we have a huge increase in cancer, cardiovascular, neurodegenerative, like senility, Alzheimer's, Parkinson's, and respiratory diseases that we now know are related to exposure to particles and other inflammatory based things. So it is really important. It's not just a fad. So what do we do? Well, you know, we can start by measuring individual metrics. And this is kind of what you see in most buildings, if you're even measuring any of this. So, you know, demand-based ventilation based on CO2 is something we hear about. PM 2.5 specifically is a known contaminant, ozone. So that's a start. And studies that have looked at or have identified, for example, small increases in PM 2.5 have shown that there are definite consequences to elevated levels. So a study at MIT showed that if you're going to be in a chess tournament, don't vacuum at the same time, because even a small increase in particles is related to more mistakes. There was a study done 2 summers ago, I guess with drones versus umpire calls, and it was shown that particles are related to incorrect calls by the umpire. And if you have high particles when you're taking a standardized test, your chance of not doing well increases. So if you want to get into a super good college, you don't want to go to jail because you paid a bunch of money, manage your indoor air. It really helps. But those are just individual contaminants. But in reality, we know that individual contaminants don't exist in isolation. So now studies are coming out, even though it's complicated to quantify the impact of mixtures, that when you look more holistically at the consequences of breathing contaminants, very low levels can be hard on our bodies. This is showing what happens to the lining of your upper airways. Over here on the left, this is a healthy view of, it's actually a mouse's trachea. You can see the little hairs, the little cilia that wash things away from your lungs to protect you. But even low levels of PM 2.5 and very low levels of ozone cause significant disruption. You can see that their inflammatory cells, the cilia, don't look as functional. There are gaps between the cells. So the bottom line is mixture. We need to look at these things together. And furthermore, even past your respiratory system, depending on what you inhale and how those things combine to create the final molecules that penetrate your body, they deposit in different areas. So for example, sulfur dioxide, so say you live near a highway, you're inhaling SO2, NO2, carbon monoxide. SO2 is very water soluble, so it'll cause irritation in your upper airways, but because it's so soluble, it really doesn't sink down deeper into your lungs. Compared to NO2, which is less soluble, and NO2 will penetrate into the smaller areas of your lung, where it can then go on to the rest of your body. So where these things go is really interesting and really important. And again, this may come as a surprise or it may not, but we now know that inhaled particles can actually get through your blood-brain barrier. Are you familiar with the blood-brain barrier? So your brain is really protected. I see Mike going no, but your brain is really protected by very tight membranes to prevent harm from, your everyday harm from getting through your brain. But we now know that particles and other contaminants can penetrate the blood-brain barrier, and particles can attach to the receptors in your nose and have sort of direct transport through your nasal cavity. So what happens what are the consequences of that? So these reactions are associated with Alzheimer's disease, Parkinson's, multiple sclerosis, which is an autoimmune disorder. So all of this is to say, managing air quality is really, really important. So this may or may not come as a surprise, but low indoor relative humidity or low indoor humidity is really hard on our bodies. We were not designed to live in an arid climate, an arid environment. There are a number of factors, but bottom line is low humidity increases our vulnerability tremendously. I could talk for a long time about that, but I'm not going to right now. Okay, so then what do we do? How do we actually, in reality, manage indoor air quality from this perspective of health? So now I'm going to tell you a little bit about what I've been doing and am doing now. So I think to really focus on indoor air quality from the health perspective, we need a health standard that quantifies the effect on our whole body of the indoor environment. So respiratory, cardiovascular, your immune system, that includes things like asthma, autoimmune disorders, immunosuppression, hyperimmune responses, as well as your brain and overall inflammation. So that may sound simple, it may sound complicated, but it is possible. So this is what I'm doing now, measuring continuously indoors. This is I hope it's okay to be a little commercial. This is the Think Light sensor. And at the same time, measure outdoor air quality. In this case, using an Induc sensor. Sometimes we use publicly available outdoor data. The more specific you are to your building, the better. Analyze the individual and combined impact of constituents. And then based on what you're seeing indoors and outdoors, decide what to do. Do you manage through your BMS system? Do you use in-space filtration or other technologies? So let's talk a little bit about, or at least show a graphic that reveals that it's not only these individual constituents that matter, but how they interact with each other and interact with your respiratory system, penetration into your cells, the inflammatory response. It's really the mix that we want to be able to quantify. And then knowing how these things work together and knowing what the outdoor air quality is, you can decide, okay, if it's a high ozone day outdoors, you may not see that, you may not smell it, but depending on what your conditions are indoors, it may be a good time to either use carbon-based filters or maybe a good time to decrease your outdoor air ventilation for a short time. Okay, so now let's talk about how you actually convince people that this is important. What is the cost benefit of managing indoor air quality for health? I was up in Maine, Mike, at the Maine Council for Indoor Air Quality and Energy. And one of the other speakers said that people who work on indoor air quality are much more interesting than people who work on energy because we don't get paid that well. I thought that was a very interesting observation. But unless you can really show a clear cost benefit, people will kind of nod their heads and go, sure. It's kind of like selling religion. It's like, yeah, it's important, but see you later. So I want to show you one good example of, in this case, a hospital that monitored the operating suites. And this was done by on site. One of my this was done by Damon Greeley and Jennifer Wagner, where they monitored the operating rooms in a I think it was a 250 bed hospital. And they only used the operating rooms that were in the green or in the yellow if it was a short laparoscopic procedure. So those were the rooms that had good environmental scores. And the output that they were looking at were surgical site infections. So for example, if you had, I don't know, a hip replacement, what were the chances of or did you get a surgical site infection? So by only using the good operating rooms, they found that the number of surgical site infections were reduced by 87%. And this is just in this one study. So you think about the people that didn't have to suffer through either, long hospitalization or died or had to have their joint replaced. I mean, the replacement replaced. It was really a tremendous savings in all sorts of metrics, but including in the financial metrics. What about energy? So did this hospital have to, was their energy consumption greater and therefore did have to pay more for that? Well, the fact was, by monitoring, they found that they were able to turn down the room air change rates, still within ASHRAE 170 guidelines. But by the monitoring, they were able to see that their particle counts and their pathogen counts were actually lower when they decreased the air change rates by 5 per hour. And then they saved, significant amount in energy. And these different numbers are because I guess the energy came from different sources at different times I'm not sure how it works, but depending on the source of the energy, they save more or less. So this is one example of a cost benefit analysis. In general, if you can, or what I do when I go to a customer, say a senior living community or a school, I have data with me that shows the benefits from the human health aspect of that building. So in a senior living community, showing that you can increase bed occupancy by having fewer senior patients going to the hospital because of viral infections. Or if you can show optimized staffing models based on less absenteeism from illness. But whatever your building type is, it's really good to have in hand data that's associated with savings from human health. So in conclusion, we can manage indoor air quality to a health standard. We have the technology, we have the data, we have medical expertise. The consequences are tremendous. The benefits are tremendous. Productivity, decreased dementia, fewer, infections from pandemics and other inflammatory diseases, all the things you see listed there. It is very impactful. And then finally, this is my humble pie slide. I'm sure you're all used to the expression, if you don't measure it, you can't manage it, right? So I do a lot of skydiving. And one day I was skydiving and my altimeter wasn't working. It was off by about 200 feet. So when I came into final, I was going too fast. I didn't realize I was so low. And unfortunately, my husband was there with a camera that day. He rarely comes, but he came that day and he photographed me doing a royal faceplant because I didn't have the right metrics. So it is important. It's important in real life versus on a day when, I knew my altimeter was working and everything was great. So why do we have buildings to begin with? Yes, we want to keep the rain off of us. We want to be comfortable. That ideally should be energy efficient, but really, truly a shelter needs to also optimize our health. And I think now we can manage buildings specifically for health. So thank you. I'm going to stop here and hopefully we can talk.
That was amazing. I wasn't lying when I said I was really excited to see you here. I have this in my car right now.
Oh, whoa.
I'm currently measuring the CO2 temperature and the humidity inside our car. I took it with me to the Better Buildings by Vermont show, and it almost hit 3,000 parts per million CO2 in one of the conferences. And the builder next to me took a picture of it and texted it to his wife because when it hits 800 in their house at home, he starts opening all the windows. So he thought she'd get a good kick out of the monitor that I was carting around. And credit to Allison Bales. I learned that trick from him. So I take it with me when I go any places.
Wow.
Well, I got a
3,000.
question. I got a question that dovetails off of that, Dr. Taylor, because I've heard mixed guidance.
That's one, Ben.
Sorry, you got me. I realized it as I did it. I've heard mixed guidance around CO2 levels because we've often been told to monitor CO2 levels as a canary in the coal mine for indoor air quality. But then you look at like work that the U.S. Navy does, and they operate, nuclear submarines at, 20,000 ppm CO2 level. And those sailors in there supposedly function at a very high level. So I've seen conflicting info about what are safe CO2 levels. Do you have any input there?
Yes, actually I have a lot of input about CO2. So if you think about carbon dioxide as a waste product from metabolism, and when we breathe, we need to have a downhill concentration gradient to get rid of that gas, right? That downhill concentration gradient would be present at much, much higher levels than we aim for. I was reading an article yesterday, and I can't remember exactly what the gradient level is, but 12,000, we're still going to be getting rid of CO2. But that's only part of the picture. The other is, what is the direct effect of slightly higher, PM at 1,200, CO2 of 1,200 or whatever threshold you want to determine? Does it make us sleepy? Maybe, probably. So that's hard on your concentration. You can adjust to that. Your body adjusts its bicarbonate levels, which is probably what happens with people in submarines. And thirdly, CO2 is a marker just for human occupation. So it's used to sort of be a benchmark for other things that we might emit. So I think using CO2 by itself is definitely suboptimal, if you want my honest opinion. The other thing that's very interesting about CO2 is, would you want to be in a space that has no CO2?
Not sure.
Did any of you, hopefully only when you were kids, do an underwater contest with one of your buddies, and before you swam underwater, you hyperventilated? So what you were doing was blowing off your CO2 so that you could stay underwater longer. And hopefully you obviously came up because you're alive. But carbon dioxide actually is what motivates us to breathe. So we do not want to be in no CO2. Or our brain wouldn't tell us to breathe. That's sort of an aside, but I think it's interesting.
Very interesting.
Do you have
It's
any
just,
thoughts about CO2 yourself?
say that again?
Do you have any opinion about using CO2 as a demand-based ventilation metric?
Well, I think it's a good trend indicator for the indoor air quality, and I think the way I see it right now, we're in a world where sensors, thankfully, are getting more and more affordable, so that we all have better access to them. Like us driving and going to conferences with relatively accurate CO2 monitors now. 5 years ago, that wasn't a thing. So I think it's useful as a trend indicator for the indoor air quality. I'm not a medical professional, so I can't tell you the impact it actually has on our health. But I know it's one of the common ones that we all turn to for what is the condition of our indoor air. Um, and the reason I ask is because I hear all of these mixed things. Is that Navy operates at very high levels of CO2, so they say that it has no impact on cognition. And then you look at NASA. NASA specifically trains astronauts to see the biological signals in their own body of high CO2 levels, so that they know when to make adjustments in the air quality on the space station. So it's like, I, as a lay carpenter or builder, am just trying to figure out, like, what do we pay attention to? What is that thing? Is CO2 a good proxy for overall air quality, or is it just what we can measure right now?
Or what we do measure right now?
Yeah.
I mean, what happens if it's a high ozone day outdoors and you have, say, particles or VOCs inside from either building materials off gassing or some process going on? You bring in ozone from the outdoor environment, your particle count's going to go sky high. It's not a good thing. So it's better than nothing, but it is not enough, in my opinion.
That was an eye opener for me, was the home chem program showing that it's not necessarily the single maybe constituent molecules, but it was their interactions. It's that ozone with the hairspray, with the olive oil from cooking, and those reactions that happen that are creating some of the really kind of nasty stuff.
Yeah. It's interesting. I love the fact here I'm talking to you, probably you aren't all medical professionals, but unfortunately we don't have enough clinicians or physicians who are in this space. And I think it's because medicine is the business of sickness. Medicine is not set up in our country anyway to make prevention profitable. So I think indoor air quality being managed for health sort of falls between, building professionals, and you guys are way ahead of most of us, but it falls in between these two professional silos. And I think consequently it's been neglected. And here we are with some big problems. So I thank you for I thank all of you.
In terms of actual monitors, things we can actually buy. A lot of us use either air things or aware. Both of those are pretty affordable, probably not super accurate. Think like Air has the flare device. Is that remotely affordable? Is it the same, or is that for more like institutional and hospital type settings?
What's your definition, Mike, of affordable?
Affordable? Is it
That's okay. You don't have to answer that.
How many zeros are there after the initial number?
I think that so I actually just recently started collaborating with ThinkLight, and they're just an amazing company, fantastic team, and great hardware and software. I think the sensors, I say I think because I haven't actually purchased one, are like $1,200.
Okay.
But the cool thing about ThinkLight, and I love this, they offer like clean air as a service. So it's like, you know how you pay for your town water if you live in that area. So ThinkLight also has, and I hope I'm getting this right, almost like a subscription service. So you pay like a monthly fee for the flare. And then if you want to implement some of their air cleaning technologies, or in-space filtration, you can do that as well. But better to go on the website than to quote me.
Okay.
It's funny that you say that because we were approached by another company that I can't recall the name of off the top of my head that was essentially offering the same thing. It's they come to you with I think it was one of the Kytera monitoring programs, but it feeds into their app and they monitor and they'll give you guidance on like what filtration needs to be done in the home and sell you, like you said, in space filtration or help you work on your HVAC system. So it's exactly that. It's clean air as a service, which was kind of mind blowing. They also do it for water so that people can understand what's happening with their drinking water in their home.
I think couple of the things I love about ThinkLight, number one, we're working on a health index, so it combines all these metrics. Number two, they have a mold risk index. So in my work, managing indoor humidity, relative humidity 40 to 60 is really good for your health. But in some buildings and some outdoor conditions, if it's really cold, if you have a leaky envelope or low insulation glass windows, you can't necessarily manage to 40% in the wintertime. I can't in my farmhouse in northern Vermont. But I like the mold index because it tells you if you're approaching conditions where you could have condensation and therefore mold growth, which I think is really valuable. So, yeah.
I've been telling people for a few years now that and this is purely a hunch on my part, but I have a feeling that the reason we have such a broad issue with childhood asthma across our country is largely because of mold from maybe less than optimal building practices that we deployed in the 70s and 80s with 6 mil poly and then the growth of air conditioning and condensation and that mold risk index that we were all unaware of for so long. And, many of us here are builders or in the trades that we've taken apart those buildings, remodeling them, and you see what's growing inside of those walls, and it's terrifying.
So what do you do if you find mold in a customer's house or yours?
We bring in a mold remediation specialist.
Yeah. So what you don't want to do is just dehumidify, because then the hyphae and the spores break up and that's disseminated into the air. And that's when you really get symptomatic. But the other thing that, if you have liquid water and you have the substrate for mold growth, you're going to have mold. But a lot of people get mixed up with water vapor and think that humidity per se can support mold. And it can't. You need, unless you're over like 85% relative humidity, mold is not hygroscopic. So just humidify. If you have a great building envelope and you're just humidifying your indoor air, say to 60%, you'll be in good shape. But yeah. Hey, Ben, the other thing I wanted to ask you, have you seen the studies on in the Amish children around asthma rates?
No.
So this kind of gets back to the microbiome and how a diverse microbiome is good for us. There's studies in North Central Europe and in the US. In the US ones, they look at Amish children who grow up in conditions where they're like rolling around in the manure and the cows and the sheep and in the barns. And the control group are Hutterite family children, which have close contact with animals, but not to the same degree of contact, not the same closeness. And the kids in the Amish families have 88% fewer infections, asthma rates than people who were really isolated from organisms. So, the whole concept of maybe we're living an overly hygienic life is also something that I think is really important.
That's like the one that when I had a child, I learned about the parents, when the pacifier would get dropped, those that would just wipe it off in the shirt and hand it back to the kid. And then those who would go and wash with soap and hot water, that the kids that had just the wiped one that maybe had environmental contaminants, whatever you want to call them on it, ended up with less autoimmune disorders later in life.
Sounds like their parents were less neurotic too.
That could also play into it.
Politically incorrect.
Sure. Mike's been coordinating questions on the back end here.
Yeah. Or, or, or with humidity, we've had a few questions. What's e, 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 your range of preferred relative humidity for, or for health versus health of the building, like building durability?
Yeah. So what's the difference between health versus the building? I mean, I'm really glad somebody's asking that because for human health, the metrics are really clear. If you're less than 40%, your respiratory cilia, the little hairs that wash things away from your lungs, become very inactive because your mucus thickens up. Your respiratory cells don't produce interferon and other protective proteins. And there's some other things that go on, but 40% for human beings is 40 to 60% is clearly beneficial. But you can't always do that safely in a building. And so the building conditions will be determined by the envelope, the outdoor conditions, again, the windows. But what frustrates me is when I see people saying that because it's hard to do, we shouldn't even consider it that, important. Like, let's just say it's hard to do, or your building, you can't do it, but don't negate the fact that it's something to aim for. So I guess to answer your question, you guys can probably answer that better than I can. I can tell you for health, 40% is really the minimum level that you'd like to be in. The flu season is really, in New England, is the heating season because we bring in outdoor air, a certain amount of absolute humidity, we heat it up. Unless you humidify, you drop the relative humidity dramatically. But Lou Harriman and I went at it at building summer camp about like the risks in some buildings. So I'm wondering what you all think about that.
So I know Joe's comment that came out of that discussion is let's protect health for 9 months out of the year, and then let's protect the building for 3 months out of the year. In cold climates, at least, right, where we have concerns over those condensing surfaces. Our guidance as a company is that we advocate for 35 to 40% relative humidity in our homes during the winter time. And I'm actually in the process now of doing a multi-year study of watching those condensing surfaces in buildings to see how far can we push it before we start to see thresholds, because we just operated a house at 37% relative humidity throughout the winter, and I only saw 12% moisture content on the sheathing, which is a perfectly safe region to be in. So that's showing me that we can push higher. That being said, this is with the classic BS trope here is it depends. We can't go telling somebody with a leaky house to be pushing their humidity up to 40, 50%, because then they're going to saturate those assemblies and have that mold growth explosion in the springtime as those condensing surfaces warm up into areas where biological growth occurs. So
it's complicated.
Ideally, fix your envelope, but I realize we don't have a magic wand.
You're preaching to the choir here on that one, very much.
Like I'm coughing right now. I humidified my house, but I was somewhere else where the relative humidity was 16%, and I never get sick. And I got the worst case of the flu, and I could feel it coming on. Like I just felt horrible in that environment. And sure enough, God, I think the only case of the flu I've ever had.
Wow.
Yeah.
What do you think about ASHRAE 62 1 and 2 for ventilation rates? Are those a good starting point, or too high, too low, or it depends?
So again, Mike, not being an engineer, I steer away from ventilation rates.
Okay.
Always knowing them, but I will say, and thankfully, with the IAQP, the indoor air quality procedure, and I work with LEED. So I think this is really good. We're moving towards measuring and managing to concentrations rather than ventilation rates per se. I mean, ventilation rates are okay if you can be sure that your outdoor air quality is good. But I don't know what you guys think about it, but I think that managing to indoor concentrations is a much more realistic and effective good approach. It's kind of like, if you measure your blood count, if you measure your hemoglobin level, you're going to measure your level, not the rate at which your blood is flowing through your heart valves. Like, let's measure what really counts.
I think thankfully we're seeing the ventilation world, at least in the residential side, is paying attention to that. And we're starting to see many of them come out with ventilation solutions that are demand based from monitors. So it's the positive trend that we're seeing. My question is what are they monitoring and what do we set those thresholds at? That's the
There's a
mystery
lot of
question.
data. There is a lot of data, even if you're not looking, even if you don't want to use for example, our combined health index, there are really good national and international standards for metrics. So the data is there.
Like a use World Health Organization guidelines or something as a starting point,
Or EPA, or interestingly, Malaysia has great standards, and I'm not sure why, but they do.
Hmm.
We need
Yeah,
people
but,
like you to
it's a
tell
change.
us.
What?
I was gonna say, we need people like you to tell us that this stuff is available so that people like us can go back and go, okay, she said we can look for this, and now we need to start asking for it, right?
Yeah, and Canada. So when I was developing my health index of combined metrics, I was looking at the Canadian standards, and they have a really good database. For example, you know how TVOCs might be considered somewhat useless because it's a mixture of red wine versus alcohol, like, hand sanitizer versus benzene or toluene, right? Ben drinks his beer.
those are VOCs that I actively encourage in my environment.
Well, in Canada, and this is what I brought into my health index, you can actually look at some of the downstream products. So say you have a TVOC spike and you're wondering if it's good, bad, or indifferent. You can look at what happens next. Do you have an ozone fault and a particle spike? Because you can be harmful VOCs are the ones that generally turn into oxidants or particles. So you can begin to differentiate bad VOCs in the whole TVOC mix by looking at what happens next. And the Canadian database looks at that, which I think is impressive.
This it excuse me, it is a medically or oriented question from the audience. Says I have a growing number of clients that say they are being treated for mold in their bloodstream, and I understand that much of this information is being promulgated by some doctors, but is not supported by solid research and peer-reviewed work. Do you have any experience or thoughts on that?
If before you accept treatment for bloodborne fungal organisms, make sure you're looking at a peer-reviewed medical journal, because if a person has like Candida or significant levels of fungal organisms in their blood, you're kind of screwed. It's not subtle. So just be careful and look at the studies that are the basis of these treatment claims.
Interesting.
Yeah.
Everybody's often looking for an ale for their woes, and maybe it's misdirected.
Yeah, the Cochrane database in medicine has really good framework for good studies. It's where the term evidence-based medicine came from, and then it was sort of adopted in evidence-based design. But they're very clear criteria. Double-blind studies that are prospective, and they're only the control versus the treatment's only revealed when the study is finished. And there are plenty of papers out there in pretty much every area, but those are the ones where you can really get good data from.
Kurt Mueller just threw a nice wrap-up question in here that I like. What air quality standards or system should I recommend to my clients? If you have the answer to that, that's tremendously useful.
Well, I mean, what am I going to say? I have one that's medically solid. But that sounds really boastful, but it's also what I do.
That's why
we're asking.
Yeah, I mean,
that's why you're here.
As far as I know, I have the most comprehensive integrated health index. Happy to share it with people. Yeah. It's the only one I know of, to tell you the truth. I mean, like Reset has a viral index. There are some indices that are based on partial metrics, but they're very partial or incomplete. So shoot me an email, stephanie@thinklike.com, and we can talk about it.
There you go.
I was gonna say, tell us where they can get it, because otherwise the chat box is gonna start going nuts.
So stephanie@thinklite.com is my email. I think
it's in the chat now.
Yeah.
Well, you're going to have a cloudy inbox for a few days. This is
yeah.
It's interesting. As a physician, I'm all for open information. But then, I go into the commercial space and it's like, whoa, wait a second. Got to put some boundaries around that. But I really am an advocate for open information.
Well, as long as you're
That's awesome.
As long as you're sharing information, the cats and dogs requests are all still prominent in the chat. So they want to know more about the cats and dogs situation. Obviously, we support beer wholeheartedly, and kissing has come up in the chat as well. So all of these great activities we certainly want to promote. But can you refer back? You mentioned dogs in the presentation, but what about cats? What's the issue here? Mike and I need to know.
Are dogs and cats and kissing the same question?
They're all in the same question. And beer.
Or is this like kissing humans?
I see a lot of dog owners that lean in and go, kisses. I think that's a real thing. I think you can leave us on that.
I've got fewer kisses from cats in my life than I have from dogs, that's for sure.
Cats just give you the finger, but their paws are so small you can't really see it.
That is funny. Well, cats are kind of a different story. Cats carry, and people who have cats carry this antigen in their blood. It's a protein called Toxoplasmosis gondii. It's not the disease toxoplasmosis, but it's a protein from cats. And believe it or not, that has been associated with anger management problems, like road rage, like bad criminal activity. I tell Bill Banfleth this because he's always got a cat walking on his desk. I'm like, Bill, put a dog on your desk. So cats truly do drive you nuts.
That's the best answer. I'm a straight up dog person, so
I'm with you here, but we just lost half the audience. Thank you for
I'm
that,
sorry. But in dogs, believe it or not, unless you're frankly allergic to dogs, they really do have a incredibly healthy microbiome. And I don't know if you know of Jack Gilbert's work. He's like the hospital microbiome guy, and he's now in San Diego. But Jack is like, hey, or I would say humidify your house, monitor, and get a dog. And you'll be in great shape.
All right.
I love it. That's a great wrap up.
In terms of kissing, that's all good. I wouldn't kiss your cat.
It has other benefits. I'll leave it at that.
Yeah.
Well, Stephanie, thank you so much for joining us, especially for joining us on our 5th anniversary show. It was a pleasure to have you with us, and we appreciate your work out there.
Well, thank you so much. This has been a lot of fun.
Yeah, I appreciate it. Ironic that we started because of COVID, and our 5th anniversary show is talking about health and indoor air quality. So thank you. I really enjoyed that.
Great. And I sent Mike my presentation. So Mike, feel free to share that.
Oh, great. Thank you very much.
And of course, our presentations, these shows always end up on YouTube. I know we're walking out the door, but it's in the chat. You can find this on YouTube. It's going to be available for a while. And of course, Stephanie shared her email. There's a lot of ways to follow up and make sure that you're doing the best thing for your clients and your families. So thank you Stephanie. And thanks all of our viewers for these last 5 years.
Well, thank you all very
Thanks,
much.
everybody.
I hope I'll see you at summer camp.
Absolutely.
Absolutely. Good night.
Take
Cheers.
care.